Start from the beginning. Wonderful. So my name is Simona. Hello, good evening to everyone. And I am the course director of the distant learning course in Neurology for Improve. So tonight, I would like to talk you through some top tips to do in your exam in general practice. I know that a neuro exam can be quite scary to do, but there are some key parts that you can do in general practice, and they can be really, really useful for you to understand a little bit more about the neuro patient and also try to localize a little bit the lesion as well. So, what are the aims of the neurological examination? The first question, of course, is it neurological? So we need to understand whether the clinical signs are actually due to a neurological condition. And then once we answer yes, eventually we need to localize the lesion, so do an anatomical diagnosis. The lesion can be focal, or we need to be aware that can have also multifocal lesions or diffuse lesions. So we can actually end up localizing to more than one areas within the nervous system. Once we localize, we list the differential diagnosis, so the possible causes of the neuroscience, and that will guide us to decide what further tests we need to run on the animal, and of course, prognosis. We can even have an idea on the prognosis already when we do a neurological examination. For example, think about patients that have brain trauma or spinal trauma. We know already, for example, that an animal that has a spinal trauma and is a grade 5, so non-ambulatory plegic with no nociception, pain sensation, has a poor prognosis. And the same thing with head trauma. We have our modified Glasgow Coma Scale that helps us with the prognosis of the patient. First thing first, we collect the history. The history is really, really important. We need to understand the onset, so when the clinical signs have started and how they have started, if they happen at a certain time during the day, and how they progress, especially if the animal has been on a treatment, how the animal responds or the clinical signs change with the treatment. There are some neurological signs that might not be obvious when we see the animal. So it is always useful to ask the owner to bring some video recording, easy to do nowadays with their mobile phones. So if the animals are doing paroxysmal events, so sudden onset of events that are abnormal. Always useful, I'm going to show you this again, always useful to have a video so we can evaluate directly. Sometimes the owner's description might not be that accurate, or they might focus on details that are not the ones we are looking for. And then the video is really useful with cats, even to assess gait, because in the consult room might not be that easy to make a cat walk in the consult room and to assess properly the gait, because they tend to hide. So again, video recording as often as possible is always, I always find really, really useful. When we list the differential diagnosis, we normally already, depending on the progression of the clinical signs through time, we have an idea already of the potential causes. For example, we know that inflammatory and neoplastic conditions, as well as degenerative conditions, have slowly progressive clinical signs, so they get worse with time.
Simona?
Yes.
Sorry to interrupt. You haven't started sharing your screen?
I haven't.
No, sorry.
I did. Okay. Should I start from the beginning then?
I don't know, but
you feel relevant. That is important for the attendees to see.
That's better.
Yeah.
Yes.
Do you see it now?
Yeah, perfect.
Yeah.
Thank you.
Wonderful.
Thank you.
So let's start from the beginning. So let's skip the first one. I think we can probably skip this one because there is nothing interesting in here. This is probably the case that I wanted to show you the video of the dog while I was talking about paroxysmal events and the importance of video recording. The dog is tail chasing. So we were here. So again, we know that we were saying that we know the inflammatory, neoplastic, and degenerative condition normally get worse with time, while traumatic and vascular diseases, they tend to affect the nervous system, they tend to stay the same or eventually improve over time. So already with the progression of the clinical science, we can start listing in our head a differential diagnosis, and metabolic diseases normally have this waxing and waning behavior. We use the acronym vitamin D as well in neurology to remind us of the big group of diseases. So V for vascular, I for inflammatory, infectious, T for traumatic, A for anomaly, M for metabolic, I again for idiopathic, N for neoplastic, and D for degenerative. To answer the question, is it neurological, we mustn't forget to do a general examination. So general examination is important because we need to make sure the animal doesn't have a systemic illness that can be the cause of the clinical signs, or also can be a comorbidity that could be important. Let's not forget, for example, our brachycephalic breed that can have upper airway problem, and therefore that can have an impact on our choice whether we anesthetize the patient or not for investigations. Or elderly patients that can have other diseases together with the neurological science. Orthopedic examination is very useful because in case of, for example, of lameness, we need to be able to identify whether the lameness is neurological or due to an orthopedic problem. I want to show you this video of this 10-year-old greyhound that was presented to us because he had abnormal gait, he was kyphotic, and had a bit of exercise intolerance, so couldn't walk very far. It looks like the dog has a hunchback, low head carriage, so this could be easily mistaken as due to a neurological problem or disease affecting the nervous system. We did a neuro exam, and the dog didn't have major abnormalities, and we palpated the hind limbs. They felt pretty cold, so we decided, and it had abdominal pain as well. We decided to do an abdominal ultrasound, and the dog has an aortic thromboembolism. It was incomplete, therefore there was still some blood going to the back legs, and therefore could still walk. But the dog had a protein-losing glomerular nephropathy, and that's why had a thrombus. So this was not due to a neurological disease, the abnormal gait. We can see this more often in cats, in which case normally the thrombus is complete. So normally the cats are non-ambulatory. Again, the abnormal gait of the dog. So when we do an anatomic diagnosis, we start localizing within the nervous system. After we do the neuro exam, we try to divide grossly the nervous system in 8 parts. We have the forebrain, the brainstem, and the cerebellum. And then we have the spinal cord. You have seen it in the previous video that Mariana has shown you. So C1, C5, C6, T2 with the cervical intumescence, T3, L3, L4, S1, S2, the lumbar intumescence, and then the caudal part of the spinal cord. So, and then, of course, let's not forget, we have the neuromuscular system, so the peripheral nervous system as well. As I said at the beginning, it's let's say it's probably good when we can localize to one area. So we have a focal lesion, and all the neuro exam points out to one part of the nervous system, but we mustn't forget that we can have multifocal lesions or diffuse lesions. So you might, again, end up localized in different areas. Of course, the difference between multifocal and diffuse is that the areas in multifocal are not continuous, while in the diffuse lesions there are several areas that are continuous anatomically with each other, and therefore we have a diffuse lesion. We divided the neuro exam in 6 main steps. I'm taking you through some of them, not all of them, of course. This will be part of lesson module 1 of our course that I will be teaching. But just to give an overview, we divide it in hands-off examination and on examination. So hands-off examination is the mental status and posture and gait. And then we do the hands-on, where we test the postural reaction, the segmental spinal reflexes, the cranial nerves, and the sensory evaluation. So let's have a look at some of the neuro exam. So when we check the animal's mentation, we check the mentation in the room. We see how the animal behaves, how it responds to the environment. And I find it always useful to ask the owners as well about the animal's behavior, because sometimes when they are in an abnormal situation, when they are stressed, or again in a concert room with us, especially cats, that can behave abnormally or be responsive in a different way to the environment. So always double check with the owner how the pet is at home anyway. We have already also a localization. If we have an abnormal notation, we know that the forebrain or the brainstem are involved. It could be because of metabolic conditions, so hepatic encephalopathy, hypoglycemia, electrolyte imbalance, or structural lesion affecting, again, the forebrain or the brainstem. So make sure if you have abnormal mentation that you run a full blood test, hematology and biochemistry on the patient with bile acid stim as well. Behavioral changes. Here you can see a dog that is head pressing. We can have different types of behavioral changes. We can have aggression. We can have pacing, where the animal keeps walking around the room constantly. It doesn't stop. We can have loss of learned behavior. Again, head pressing, or the hemineglect syndrome we're going to see in a minute. Head pressing is due to a forebrain disease, normally due to raised intracranial pressure. We have a Yorkie that is circling, has white circles to the right. The gait, we can say it's not that abnormal. And the dog had left-sided proprioceptive deficits. And he was affected by a right forebrain lesion. So this is called hemineglect syndrome. Maybe have a circle to one side and the deficits on the other side, or hemi-inattention syndrome. Another video of a dog that is circling. This dog, unfortunately, the owners stepped on it, causing a brainstem damage, and specifically to the vestibular system. So the dog cannot stand up and keep balance, and just rolls. His circling is so bad, his disease is so bad that just can't stay still. So already we can see the difference. Forebrain, the animal can still walk. Brainstem, often the gait is affected. So going back to what we said earlier, so if an animal is circling, can be vestibular or forebrain, and we have seen that the gait can make a difference between the vestibular and the forebrain localization. Posture. Two postures that you could see commonly during your work, in clinical, in practice, are head tilt and head turn. So on your left, you have a head turn. So the dog is turning its head towards the side. So the eyes and the ears are kept horizontal, but the nose is turned towards the side. This is again due often to a forebrain lesion and sometimes to neck pain as well. On your right-hand side, you have a Cocker Spaniel with head tilt. It's a right-sided head tilt. You can appreciate that the ears are not more horizontal, but they are like on a vertical or oblique line. So the nose is pointing towards you, but the head is tilted to one side. So it's left-sided head tilt. The difference is that head turn, again, we said it's more often forebrain problem. The head tilt is more often vestibular. So we are already localizing. Posture. Posture is important, very important. I wanted to show you this because it was a quite interesting case. So this dog was running in the park, happily running in the park. All of a sudden, yelped and fell on the floor, and the owner picked him up like this and took it to the vet. So we have seen it a couple of hours later. The dog is non-ambulatory, and at first sight, it might look that the disease is affecting the four limbs. But actually, this dog had an acute thoracolumbar lesion that is affecting, of course, the hind limbs. So we walk the dog. As you can see, he has a harness and a sling. So we lift him up, walked him, and he actually had good movement, a good gait in the front limbs. Although the extensor tone was increased and not much, a little bit movement, but it was paralytic. He couldn't really hold up his weight with the hind limbs. So this is due to an acute trauma to the spinal cord. It doesn't have a prognostic value. It just tells us there's been an acute trauma to the spinal cord, and therefore there's a loss of inhibition of the extensor tone to the front limbs. That's why they have hyperextension of the front limbs, but the front limbs have good movements, and this is called a Schiff-Sharrington syndrome. When we evaluate the gait, we need to understand what limbs are affected. Make sure you look at the animal walk on a corridor, on a lead, back and forth as many times as you need to make sure you're trying to understand which legs are affected and the type of abnormal gait. We divide the abnormal gait in three different big groups. We have uncoordination or ataxia, weakness or paresis, and lameness. We're going to see them quickly in a minute. And make sure you, as we have seen with the dog earlier, that you evaluate non-ambulatory patients. So make sure that you have harnesses, slings, towels, help as well, because some dogs can be heavy to lift up on your own, and try to see if there are movements in the legs. So let's have a look quickly at ataxia. We divide the ataxia in three big groups. We have sensory ataxia, vestibular, and cerebellar. We are going to see videos of each of them. So sensory ataxia is the norm, so we said ataxia in coordination. So sensory ataxia as abnormal proprioception, and that can be paresis if the ataxia is due to a brainstem or a spinal lesion. Vestibular ataxia, the proprioception can be normal or abnormal, depending whether it's peripheral or central, but there are also vestibular signs. So we can have head tilt, nystagmus, strabismus, for example. If it's cerebellar ataxia, the proprioception is normally normal, and we can have cerebellar signs like head tremors. So this is an elderly dog that came to see us because of ataxia. As you can see, there is total uncoordination of the limbs. It looks like the front limbs work with one engine and the hind limbs with a different one. So short stride step at the front, wide base stance, and slow steps in the hinds. We actually call it a two-engines gait. The dog had, let's see, have a look at him again, a bit of low head carriage as well. This is a typical example of sensory ataxia due to a spinal lesion. So we did a neuro exam, full placement. Already wanted to show, we are going to talk about postural reaction soon, but you can really appreciate the pole placement, and it's abnormal in both hind limbs. As you can see, we do it several times, and there is good support to the animal. It's not always easy, as you can see, especially when the animal has abnormal gait, and the front limbs as well. And it's absent in the front as well. Again, doing several times until you're convinced that it is consistent with the results. And always remember, when there is a cannula on the leg, sometimes we can have a little bit of, some dogs just freeze when they have a cannula, so don't do anything. So keep that in mind We try the withdrawal from standing and the hind limbs. So segmental spinal reflex. It is quite good. In the front limb, there's nothing. It's not flexing the leg away. This is the right side. We try on the left. Turn around for the video. Hind limb there. And left front limb, listen, it's not there. So we localize to the caudal cervical. He can fit his pill. Localize to the caudal cervical spinal cord. This dog had a disc-associated wobbler syndrome. Another example of ataxia, different. So we can see already that there is uncoordination and a sort of hypermetria in the gait. Really uncoordinated, as you can see, really losing. This dog is having a completely normal quality of life, but it has a totally abnormal gait with dysmetria, hypermetria in all four limbs. We did a neuro exam. Just show you the postural reactions. Pretty good, in my opinion. Paw placement is good. Withdrawal is good. Front limb. Always remember to give support. You see how many times we repeat it to make sure it's consistent. So we do one side and the other side, always do both sides, of course, for comparison and for localization as well, of course. So we have seen earlier the type of ataxia that has normal postural reaction is the cerebellar ataxia. And in fact, this dog had what we call a hereditary cerebellar degeneration, which is a congenital disorder. Okay. Hopping from medial to lateral, support, 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 and just the one leg that we are testing on the floor, and we hop always from medial to lateral, not the other way around. Okay. A Labrador with right-sided head tilt and ataxia on all four limbs. It's really, you can see it will lose its balance. His postural reactions were abnormal. The dog had a central vestibular disease and unfortunately had a brain tumor. So challenging it was for him to turn around, and obvious head tilt as well. He had a brainstem tumor. Next case, I just wanted to show you this, just out of curiosity, because I think it's quite interesting. This dog had a pododermatitis and was treated with metronidazole at high doses and started developing ataxia and head swaying from side to side. This is due to bilateral vestibular signs, central vestibular signs, and we stopped, of course, the metronidazole. We gave him supported treatment for a week, and he actually got much better and back to normal within a week. So make sure that if you need to use metronidazole, do not use more than 15 mg per kg twice a day. So we've seen ataxia and coordination. This is paresis. Paresis or plegia is weakness. We call it paresis when the animal has voluntary movements, and we call it plegia when there are no voluntary movements. So it's really important to support the animal and check if the movements are there in the legs that we are assessing. And of course, we can add a prefix mono, para, hemi, tetra, depending on what legs are affected. This Labrador came in non-ambulatory. You can see in a minute that he can't stand up, he can't move when he's on the floor. But we put on a sling harness. It's a really helpful device. As you can see, there are two people, so they can share the weight. And we just move it slowly around the room, back and forth, to check for movement. So this dog is tetraparetic, is non-ambulatory tetraparetic. As you can see, as soon as they let go, it just flops on the floor. But we have movements. Knowing whether there are movements or not, whether the animal is paretic or plegic, is very useful for prognostic, for the prognosis of a good prognostic value. So we need to check this because it will be important for our discussion with the owner and the decision making, and then we do in terms of diagnosis and treatment. So always walk non-ambulatory patients. I keep stretching this, but it's really important. This is a German Shepherd that was instead paraplegic, so hind limbs. So disease affected the hind limbs. The front limbs are normal. Unfortunately, is aggressive, but the hind limbs have absolutely no movement whatsoever. And even the tail is flaccid as well. It's just swaying around, hanging there, but there is no voluntary movement at this level. And in this case, it's really important to test instead nociception, so deep pain sensation. We are going to see this in a second. Postural reactions, so hands-on. The ones that we do more often are the paw placement and the hopping. We have seen them before. I'm going to show them again to you. They test the same pathways. We just do both to have more information. But if, like in the lab, the two engines at Labrador, the paw placement is already completely abnormal, completely absent, there might not be the need to do hopping. Sometimes we do both when we need more information or it's not clear cut. So this golden, we do the paw placement on the right hind limb, and it's quite good. You can already appreciate that the left hind is already knuckling on its own. We test for muscle tone as well. Paw placement. Again, several times withdrawal. It's quite good. Right front limb, normal, and normal withdrawal. Look, always support the animal, and again, hopping from medial to lateral. Do it several times if you're not convinced, because the animals might not be cooperative. Left hind limb, totally absent of paw placement. So there is an asymmetry between the right and the left side. And actually, it's quite reduced withdrawal. So we have a left hind limb monoparesis. And he's feeling his paw, which is good. But we had movements. It just needed support. Yeah, and as you can see, there is no hopping. The leg is not hopping. Front limbs, important to give support, even at the back train. So there we go, perfect. Sometimes holding the back legs between the knees is quite helpful if you're standing at the back. The spinal reflexes help us narrow down within the nervous system. So with the proprioception, we normally answer the question, is it neurological or not? And then with the rest of the neurological exam, we start narrowing down. So we have the spinal reflexes, the test, the sensory afferent branch, of course, the receptor, the nerve, a segment of the spinal cord, and then the motor part, which is the nerve and the neuromuscular junction. So if we put together the information of the proprioception, the segmental spinal reflexes, we can start narrowing down the lesion within the spinal cord, for example. So we know that a lesion that is above C5 will give upper motor neuron signs to the thoracic and the pelvic limbs, which means that we can have abnormal gait and abnormal proprioception, but the segmental spinal reflexes will be normal in all legs. If the lesion is affecting the cervical intumescence, so C6, C2, we will have lower motor neuron signs in the thoracic limbs, therefore abnormal proprioception and gait, but also abnormal segmental spinal reflexes and upper motor neuron signs in the pelvic limbs. TTL3, the thoracic limbs will be normal, and the pelvic limbs will have upper motor neuron signs, and L4S2, normal. Again, thoracic limbs and the pelvic limbs will have lower motor neuron signs, so abnormal segmental spinal reflexes on top of abnormal proprioception and gait. So we can already, with the information of the proprioception, the gait, and the segmental spinal reflex, start narrowing down within the spinal cord. So the segmental spinal reflexes, the ones that we test more often in the thoracic limbs, are the withdrawal and the extensor carpi radialis. I would say probably the withdrawal is the one that we test honestly more often. I think I have a video here of right front monoparesis. If there is no withdrawal, so we pinch the pose and we expect the animal to flex the leg completely. All joints need to be flexed. If the withdrawal is abnormal, we test for the muscle tone as well. So left front is really good withdrawal, and the right, it was completely abnormal. That was completely absent. So it's a right front monoparesis. In the pelvic limbs, we check two major reflexes. One is the withdrawal. The test mainly the sciatic nerve, and we can see in this big dog, the right hind has a good withdrawal. The flexion of all the joints, especially the hock. And on the left side, the animal is knuckling. As you can see, the hock is not flexing, and is typical of a sciatic nerve lesion. So the hip is flexing a bit because that's the femoral nerve, but the hock is not. That's a sciatic nerve. So patellar reflex. So we have to use the long part of the hammer. We try to localize the patellar tendon and gently hammer it. And then the leg should kick. That's a normal patellar reflex. We test the femoral nerve, L4, L5 spinal cord. If there is an abnormality, normally there is also abnormal gait as well, because when there is a lesion affecting the femoral nerve, the function of the femoral nerve, the animal doesn't bear weight very, very well. But we know that in case of orthopedic condition, especially affecting the stifle or in old dogs, we can have reduced or absent patellar reflex. This is not due to the neurological disease, it's just related to, again, old age and local orthopedic disease. Very important, very, very important is to assess nociception or deep pain sensation. So in an animal that is pelagic, so is non-ambulatory and has no movement, we need to test for deep pain because as a prognostic factor, the absence of deep pain sensation carries a poor prognosis. So we need to pinch the toes at the level of the nail bed with a mosquito, hard. We need the animal, unfortunately, we need the animal feels pain at that point. So warn the owners if you do it in front of them, but it's really important. And the way the animal shows pain, this dog is withdrawing the leg. That is just a reflex. I'll show you again. Sorry. But that is not a sign of deep pain sensation. If we want the animal to react, we want a behavioral manifestation of the feeling. So we want the animal to turn the head, to try to bite, to growl, to cry, to just show us that information is reaching the brain and is feeling that we are pinching the toes. And make sure you pinch all toes because they can be innervated by different nerves. And also that you compare with another area. If you think if the animal is paraplegic, it should feel the pain in the front limbs. So make sure you compare. Some dogs can be so good, so stoic, they don't react even when you pinch them hard. So because it's such an important prognostic factor, make sure that you really are convinced that there is no sensation, there's no feeling in that. As you have seen the German Shepherd, that would try to lift the head and bite, so it did have pain sensation. It is very important in animals that have incontinence to test the tail and the anus. So to test the perineal reflex by pinching the perineum, we should have a contraction of the anus. And so the reflex and the sensation at that level, because a loss of nociception in patients that are incontinent carries a poor prognosis, even if the patient regained the ability to walk, like in this case. But if they have a flaccid tail, you can test the sensation, also the deep pain in the tail. So we're pinching the tail and the dog is not sitting down, like nothing is happening. And then we test. We can see already that the anus is flaccid, so there is no tone. And we test sensation and reflex at that level. And the dog is absolutely, nothing is happening at any level. It's not reacting. There is no local reflex. This carries a poor prognosis in terms of recovery of the continence, even if the animal is walking. The cutaneous trunci helps us localize the lesion within the spinal cord. We pinch the skin either side of the spine, and we look for, there you go, for contraction of the muscles. We test it from L1 to T1, from caudal to cranial. And when the sensation, when the contraction appears, we know that the lesion is at that level. So we test so the information goes in, the sensation goes in from the pinching through the local dermatomes. It runs up on the spinal cord and exits at the level of C8, T1 with the lateral thoracic nerve that stimulates the contraction of the cutaneous trunci muscles. So a lesion on the spinal cord can affect the information going up. So the cutaneous trunci is lost caudally to the lesion. And also, if we have a lesion at C8-1, where the lateral thoracic nerve exits, we can have absent cutaneous trunci all over the spinal cord, all over the back. So in this case, you can see there is no cutaneous trunci, no panniculus, and then it appears at this level. So we can localize pretty much around this area, the lesion at the level of the spinal cord. This dog instead had a right front limb monoparesis. He has little movement. This was due to a lesion at C8-1 spinal cord. So we did the cutaneous trunci on the right side. As you can see, we pinch. There is no contraction on this side, but there is a contraction on the other side because the information goes in at the level of the dermatomes, but it doesn't. But the lateral thoracic nerve is not capable of contracting, but there is a bit of contraction on the other side. Spinal palpation, we finished with spinal palpation, very important to localize again at the level of the spinal cord. I normally palpate gently, give good support under the belly and the chest. Palpate first gently, and then if the animal doesn't feel any pain and I suspect a spinal problem, then I apply more pressure from caudal to cranial, cranial to caudal. We palpate the transverse processes in the cervical spinal cord. If the cervical spine, if the animal feels already pain at that level, we don't move the neck around. But if it is not bothered by that, then we can try moving the head around to make sure there is no cervical pain. And for the thoracolumbar spinal cord, we palpate at the level of the spinous processes. So, in conclusion, top tips. First of all, we need to understand whether the problem is a neurological. Remember to divide more or less the nervous system in 8 regions that will help you narrow down the problem. Give importance to hands-off examination, posture and gait, that you can already assess when the animal is in the waiting room and is walking with the owner in the consult room with you. Make sure you evaluate non-ambulatory patients. Make sure you lift them up and see if there is movement in the legs. Remember the 3 types of ataxia, because that will help you localize the different areas of the nervous system. The use of the cutaneous trunci to localize in the spinal cord, and testing the nociception. Always look out for behavioral reaction when you test the nociception, and not for withdrawal, not for movement of the leg, but behavioral changes. Thank you very much for listening.